You're listening to Conferences Online Allergy from Children's Mercy Hospital in Kansas City, Missouri. Today is August 25th, 2023. Our topic today, severe combined immune deficiency, past, present, and future. Our presenter is Dr. Eyal Grunebaum. He's a professor of immunology and pediatrics at the University of Toronto and senior scientist at the Hospital for Sick Children in Toronto, Canada.
So welcome everybody. You're listening to Conferences Online Allergy from Children's Mercy Hospital in Kansas City, Missouri. Today is August 25th, and today we have Dr. Eyal Grunebaum, who is a clinician scientist at the Hospital for Sick Children in Toronto. His clinical and research focus for many years have been on the diagnosis and management of inborn errors of immunity, especially severe combined immune deficiency, which will also be the topic of his talk today. Thanks again for coming.
Thank you, Thao, for the introduction. I hope all are having a nice summer. As mentioned, I'm Eyal. I'm from Toronto, where I've been managing patients with severe combined immune deficiency for many years. So my objectives today are to describe what used to be classical SCID, severe combined immune deficiency, which is now actually only rarely seen in North America, thanks to newborn screening. I will then talk about some of the current and future directions in the management of patients with severe combined immune deficiency, and finish with what is considered the new frontier of immune deficiency, the combined immune deficiency. And I'll explain the differences between these conditions. I'll start with a description of a patient, an 8-month-old patient, who was referred to me already in 2007. And he was sent because of recurrent otitis, pneumonia, and failure to thrive. The family history was relevant for a maternal uncle that died from unknown causes back in Poland, where the family originated from. Otherwise, there were no real red flags to suggest an immune deficiency. The physical examination, on the other hand, was quite alarming. The baby was cachectic, dyspneic, and had significant oral thrush. I could not palpate any lymph nodes. It was very difficult to see tonsils in him. He did not have any signs of Owen syndrome, which I'll just mention briefly. They include a erythrodermic rash, alopecia, and organomegaly, and are due to uncontrolled inflammation. But as I said, the patient did not have Owen syndrome. Chest X-ray suggested bilateral pneumonia, and importantly, the thymus, which can easily be seen as a large sail on this image, and I hope you can see my pointer, was actually absent. So, as you can see in our patient, this was there was no evidence for thymus. The absence of the thymus was later confirmed by ultrasound, and chest X-ray and chest CT further demonstrated ground glass opacities and septal thickening. But the biggest clues came in the laboratory evaluations. So his CBC was normal except for moderate lymphopenia. He had also very low IgG. However, this could have been due to the physiological nadir that reaches its minimum values at about 6 months of age. But his IgA and IgM were also undetectable, which with his most recent infections, I would have already expected to see some immunoglobulins. NP swab was negative, but PCR of his blood did identify CMV. And what was most alarming was that his bronchoalveolar lavage revealed the presence of CMV and pneumocystis jirovecii, which indicated clearly that he had a severe T-cell deficiency, although at this point, I still did not know whether it was a primary T-cell abnormality or secondary T-cell abnormality. So before proceeding, we first looked for the possibility that this was a secondary immune deficiency. Secondary immune deficiencies can be due to infections such as HIV or TB, severe sepsis, or other major sicknesses in the perinatal period. Medications, including medications that the mom received during the later stages of her pregnancy, nutritional deficits, GI losses, can all lead to a secondary immune deficiency. Malignancy and rheumatological diseases are also on the differential diagnosis. But after excluding all of this, we're left with a primary immune deficiency. So the next stage in the evaluation is to look by flow cytometry at the lymphocyte subsets of this patient. And indeed, this patient had very low T cells, both the CD4 T helper cells and the CD8 T suppressor cells were very low. In addition, the patient also had very low NK cell numbers, while the B cells were preserved. Further evaluation of the patient's T cells showed that the naive T cells were practically absent, and the few T cells that were in the periphery did not respond to stimulation with phytohemagglutinins or anti-CD3 stimulation, which are the typical tests that we use to identify or to assess the response of T cells in vitro. So all of this established that the patient had a severe combined immune deficiency, what we call a T minus, absent T cells, B plus, B cells present, NK cells absent, NK minus, SCID. Now, this nomenclature is important because the plus and minus designation that comes from the phenotyping of the lymphocytes can give us at least a preliminary clue to the specific etiology of the severe immune deficiency. For example, absence of only T cells with preservation of both the B cells and NK cells can indicate a thymic defect, such as Lejour syndrome, or abnormalities in the CD3 chain on the T cells. By absence of both T cells and natural killer cells suggested a problem in the IL-2 receptor gamma chain. Absence of all three cells, a T minus, B minus, NK minus, suggests adenosine deaminase deficiency, while absence of T cells and B cells, but preservation of natural killer cells suggests defects in the recombination genes such as RAG1 and RAG2. So it is important to look at this T, B, and NK cell phenotyping, although I should caution you that there are some discrepancies in the phenotype. This is a really nice table that I often use when I look at patients with severe combined immune deficiency. And it's updated every couple of years, where they look where the presence or absence of B cells and NK cells tells you which group of conditions you need to look at. Nevertheless, as I mentioned, there's discrepancy and there's new conditions added frequently. So eventually, in all these patients, we do sequence their DNA to get an exact identification of the genetic cause for the immune deficiency. In our baby, who had B cells but no T cells or NK cells, the cause of the severe combined immune deficiency was actually a defect in the IL-2 receptor gamma gene, also known as the common gamma chain. Now, this is important because it is the most common cause of severe combined immune deficiency, and it impairs both the development of T cells and B cells while allowing B cells to develop but not to function. Hence, the phenotype that we see in our patient. As I mentioned, this is the most common cause of severe combined immune deficiency in North America. And it's encoded on the X chromosome, which is why it is also known as X-linked SCIDs, where males are affected and females are carriers. So what do we do with these patients? So first of all, remember, severe combined immune deficiency is a medical emergency. I tell my trainees, this is probably the only time to call me in the middle of the night. These patients can crash frequently. And so we need to start treatment, supportive care, as soon as possible. We need to look whether or not they have infections, treat these infections, especially CMV and pneumocystis jirovecii pneumonia, prevent infections by isolating them and minimizing their exposure to team members and family, begin IVIG and PJP prophylaxis, as well as antibacterial and antifungal prophylaxis. But eventually, all of these are supportive measures, and they're only temporary. What these kids really need is a new immune system. And so the next step is to perform urgent HLA typing for the patient and close family members who might be potential donors for allogeneic hematopoietic stem cell transplant. As mentioned earlier, it is also critical to establish the precise etiology of the severe immune deficiency, as it will determine whether a hematopoietic stem cell transplant is beneficial, because there are cases where we can now actually do thymic transplant, something that if someone is interested, I can talk later in the question period. But definitely we need to establish the etiology to determine if and how to do the bone marrow transplant. Briefly, for our patient, it was difficult to control his infections, yet eventually we were able to find an unrelated donor, and we got him to transplant after about 3 months from diagnosis. He did have some additional complications after the transplant, but has recovered. And now, about 16 years later, he's clinically well, although he does suffer from persistent lung damage and hearing impairment. So that's the past. Fast forward to our time. In 2018, I was referred a 1 week-old baby who was sent to me, although he was completely asymptomatic and had no family history of immune deficiency. He was sent to me because the Ontario Newborn Screening Program identified that he had absent T-cell receptor excision circle, and this was suggestive of a profound T-cell immune deficiency. And I'll talk about that in a minute. So after excluding secondary causes for T-cell immune deficiency, we confirmed by flow cytometry that he too had absence of NK cells and T cells, while B cells were normal. So again, a T minus B plus NK minus SCID. Rapid DNA sequencing demonstrated that he had an IL-2 receptor gamma mutation, and I won't go into what the IL-2 receptor gamma is because we just talked about that. But I do want to talk more about the T-cell receptor excision circle assay, because this is now something that we are using quite frequently, and it's really important that you understand the concept and how we use it. So for many years, clinicians and scientists had struggled on how to best screen babies for severe combined immune deficiency until a reliable solution, the TEREC assay, was established. It is important to remember that T cells rearrange their VDJ chains to create a specific T cell receptor. And to do that, they require some DNA segments to be cut between the V, D, and J genes. And when these pieces of DNA are cut, and actually are chunk DNA, they tend to form a circle. a circle that is resistant to degradation. And so it actually remains within the cell, as within the thymocytes, as these cells leave the thymus. And Dr. Daniel Dueck from the NIH thought that he could use these TRECs to detect generation of new T cells in patients with HIV. But at the same time, Dr. Jennifer Puck, who was at the NIH before moving to sunny California, decided or tried to see whether or not she could detect these TRECs also in dried blood spots that are routinely collected from babies. These are the Guthrie cards. And she was able to show that you could quantify the TRECs as a surrogate marker for new T cells that are produced by the thymus. Since then, the TREC assay has proven itself as a robust screening tool for severe combined immune deficiency. And absence of TREC is practically pathognomonic for severe combined immune deficiency. We are still challenged, and that's important to remember, when the TRECs are low, not completely absent, but low, as the cutoff that affects the sensitivity and specificity of the assay. So in most places, only about 10% of the infants with reduced, not absent, but reduced TRECs will eventually end up as suffering from severe combined immune deficiency. But nevertheless, it's important for us to evaluate each one of these kids, as we do not want to miss any patient with severe combined immune deficiency. Some of the causes for a false positive, that is a positive newborn screening for TREC that will not end up as suffering from severe combined immune deficiency. So some of the false positive causes are prematurity, low birth weight, or sepsis in the neonate. Even severe respiratory distress syndrome can cause low TRECs. Nevertheless, it is important to assess all of these kids. It's also important to remember that there might be a false negative. That is, there are a few cases of severe combined immune deficiency or profound T cell immune deficiencies that might be missed. So it's important to remain vigilant for the possibility of SCID, even if the newborn screening was reported to be normal. Some of the more common causes include MHC class II deficiency, adenosine deaminase deficiency, as well as technical challenges, as the information may not have reached, the Guthrie card may not have reached the testing center. The testing center may have not reported it on time, but altogether, the newborn screening for severe combined immune deficiency has made a huge difference in the diagnosis and the management of patients with severe combined immune deficiency. So this is a slide from the Primary Immune Deficiency Treatment Consortium, where they reported on the change of the effects of newborn screening on the diagnosis of severe combined immune deficiency. As you can see, in 2010, most of the patients with severe combined immune deficiency were diagnosed because of infections, while in 2014, most of the patients are now being diagnosed because of newborn screening. The change in diagnosis also had an impact on the management because patients are now usually clinically well, so there's actually no indication to admit them to the hospital, which means that the isolation needs to be done at home by the family. So it needs to be a family that you can rely on, that they will follow your instructions and guidelines. We do need to be able to see them every week or two in the hospital, in our clinic, which means that the family needs to be in a reasonable distance from the hospital. So some families had to move closer to the major transplant centers. During these clinic visits, we monitor them closely for infections, both clinically and using various laboratory studies. We often start prophylactic antimicrobial and immunoglobulin at about 1 month of age. And whether or not to breastfeed depends on whether the mom has had CMV or not. And so if there's a chance that she will transfer CMV to the baby, we usually advise against breastfeeding. The early diagnosis of severe combined immune deficiency, when the patients are still asymptomatic, had also a significant impact on the outcome of affected babies. In the past, unless the patient had an HLA-matched sibling donor, usually the outcome was about 70 to 80% survival, which means that 3 out of 10 patients on average died. But this changed dramatically among the kids who were diagnosed after 2010, where the survival is now over 90%. Amazing. All of this thanks to the early diagnosis of these patients. Moreover, if there is a HLA-matched sibling donor, the survival goes up to the long-term survival goes up to almost 100%. So while parents don't like us using the name cure, we can now, in most of these patients, successfully correct the immune deficiency. Amazing. Several factors were found to still be associated with reduced survival. These include patients who developed infections while awaiting for transplant. So it's important to try and make sure that they don't get any infections with very strict isolation. If you perform the transplant late, usually after 3 months of age, that's also was associated with decreased survival, as well as being Black or belonging to an African-American group. And that probably reflects the difficulties in finding appropriate donor. Also, there's a few types of severe combined immune deficiency, such as adenosine deaminase deficiency and RAG1 and RAG2, that are associated with decreased survival. Again, probably because these are identified a little bit later than the classical patients with X-linked IL-2 receptor gamma deficiency. So after making the diagnosis, we still have some significant questions that we had to establish in our patient. Our patient did not have any matched sibling donor, so we were debating whether or not we should proceed with a transplant using one of his parents who were haploidentical or half identical in terms of their HLA, human lymphocyte antigen match, or to search for an HLA matched yet unrelated donor. So that was one of the first big questions we had to determine. Then how to prepare the patient, what type of conditioning should we give him before the transplant, how to best prevent graft versus host disease in him, and should we continue with allogeneic transplant, or should we look for autologous gene therapy? And these are all points that I'm going to address in the next couple of slides. So which donor should we use when there is no HLA-matched sibling donor? There are two main options: a parent who's only matched at half of the HLA loci, or an HLA-matched but unrelated donor. There are advantages and disadvantages to each approach. HLA haploidentical donors are almost always available, and the parents are eager to donate and save their baby. So transplants can be done quickly compared to the several months it takes to identify an unrelated donor. However, HLA haplotransplants require the removal of T cells from the product, which is costly and not easily achieved. And the T cell depletion leads to slow immune reconstitution and higher chances of graft failure. So in the long run, HLA haplotransplants have been more complicated to do, at least in the past. So we had shown previously that the outcome of patients with severe combined immune deficiency was significantly better when they received unrelated donors compared to haploidentical transplants. But this was when this study was done in an era where SCID was diagnosed at an older age, and kids often came to transplant with infections. Since 2010, when we are able to identify kids with newborn screening and they come without infections, we actually have shown that both using an unrelated donor or haploidentical transplant are associated with greater than 90% long-term survival. And so now it really depends on the center's experience and the parent's preference, because both of them give you greater than 90% survival. Amazing. Okay, what about the conditioning, the chemotherapy? It's another important question that we've made significant advances. So I wanted to talk about this. First of all, why do these patients actually need any conditioning? They have no functional T cells, and so they're unable to reject T cells. Yet it's important to remember that T cells and B cells need to crosstalk for antigen presentation and for B cells to be able to produce antibodies. Also, to achieve lifelong donor-derived T cell production from hematopoietic stem cells, we actually need to engraft donor progenitor cells. Hence, we do need to remove the recipient's hematopoietic stem cells. We also know this because in the past, when we did bone marrow transplants for patients with severe combined immune deficiency with no conditioning whatsoever, many of them suffered graft rejection, and 50% of them needed to continue to receive immunoglobulin replacement. So some centers tried the opposite approach, tried to use myeloablative conditioning with chemotherapy. They used protocols, regimens that were successful in patients with malignancy. And so they were able to get good bone marrow transplant engraftment, but the price was too high because patients developed a lot of complications, liver complications, brain abnormalities, lung toxicity, and as well as high frequency of graft versus host disease. So this approach also was not very beneficial. Eventually, we now realize that it's important to give not too much, not too little. So now many centers are now using a reduced intensity, reduced toxicity regimen that is considered the just right amount. However, I should caution you that the long-term efficacy of this approach is still not clear. So now the PADTC, the Primary Immune Deficiency Treatment Consortium, is doing a prospective study looking at the conditioning amount required to establish long-term immune reconstitution in patients diagnosed early in life. I mentioned graft versus host disease and its prevention. This is another frontier where there have been significant advances in recent years. When talking about prevention of graft versus host disease, it's important to appreciate that there are two main ways to do this. One is to remove the donor T cells from the graft ex vivo, outside of the body, prior to the infusion of the cells. Right. The other approach is to remove the T cells, the donor T cells, in vivo, in the patient after the transplant. In the past, we used to remove the donor T cells ex vivo either with lectin, which was very cumbersome and only very few centers could do this, or by selecting CD4 positive expressing cells, which are not T cells. However, this approach was often complicated by graft failure. Recently, advances in selecting cells using fluorescent activated cell sorting have improved our ability to remove T cells responsible for graft versus host disease while preserving the cells that are important to fight infections. However, there is still complications with this process. It's very expensive and technically challenging. So it's still not adopted in all centers, but we are getting better. And I do anticipate that this will be the main mechanism by which we're going to do hematopoietic stem cell transplants in the near future. In vivo depletion of T cells has also undergone significant advances. So in the past, what we used to do, we used to give antibodies such as antithymocyte globulin or alemtuzumab. These are monoclonal antibodies that target T, B, and NK cells just prior to the transplant. Or we used to give steroids or other immunosuppressants just after the transplant. And this was done to target the donor T cells, who are now in the recipient. But there was a lot of complications of these from these methods. Patients were susceptible to infections for a long period, and patients had a lot of adverse effects from the steroids, from the immunosuppressants. Recently, a new approach was developed where we're using low dose of cyclophosphamide 3 or 4 days after the transplant. And this amount targets only the donor T cells that are now responding to the recipient's antigens. And so this has proven to be very, very effective. Also, because it's cheap and readily available, this is gaining a lot of support in many centers. Nevertheless, despite both the ex vivo and the in vivo advances that we've been able to achieve with graft versus host disease, graft versus host disease remains the main cause of morbidity or mortality in patients with severe combined immunodeficiency and other patients with primary immunodeficiency. And so the goal, or the holy grail, is to try to avoid graft versus host disease altogether. And that is something that can be achieved by doing gene therapy. So autologous gene therapy. How do we do gene therapy? Well, we first engineer a virus that can enter the cells and integrate into the cell's DNA, but will not replicate on its own. So will not be dangerous to the patient. We then insert our gene of interest into the virus. We then take the engineered virus and sprinkle it, add it to the bone marrow from the recipient, from the patient. And then we infuse the cells which contain the new virus and the new DNA into the patient and allow these cells to expand in the patient and exert their biological effect within the patient. So Investigators have been trying to develop gene therapy for X-linked SCID since the identification of the gene for this condition. The initial attempts failed, which were done with the gamma retrovirus, failed as about 25% of the patients developed malignancies. Finally, in 2014, a safer delivery method was developed. And in further studies in 2019, they were able to develop a safe lentivirus to deliver the gamma common chain into the patient's cells. And with a little bit of a small dose of busulfan, they were able to correct the immune deficiency in the patients. Follow-up of these patients demonstrated that it did not cause any malignancy, and this approach has now been adopted for a growing number of primary immune deficiencies. And I won't go through all of these, but the concept is very similar. Actually, the only condition that I will mention is ADA deficiency, because adenosine deaminase deficiency is we're the most experienced with gene therapy, with autologous gene therapy has been achieved. There have been more than 100 patients with ADA deficiency who have received gene therapy, and they're with amazing success. One patient was recently reported to have developed malignancy, but one out of more than 100 is still considered a very, very good success rate, and so much that it's now approved for clinical use in Europe and being evaluated by the FDA. So I have no doubt that gene therapy will be the main definitive treatment for most inborn errors of immunity in the near future. The last topic I want to discuss is combined immune deficiency. Again, not the severe combined immune deficiency, but the combined immune deficiency. What's the difference? The difference is that combined immune deficiencies usually have a milder clinical and laboratory phenotype. They represent a continuous spectrum, but again, patients with combined immune deficiency are not as severe as patients with severe combined immune deficiency. These nuances become important, and people have tried to come up with some guidelines on how to identify one versus the other. And I'm using here the guidelines that the Primary Immune Deficiency Treatment Consortium has recently published, where they consider typical severe combined immune deficiency as having less than 50 T cells, and identifying a pathogenic variant in a SCID-associated gene, not having any T cells or any TREX or very low TREX. This is not easy, and as you can see, there is quite some overlap between the typical SCID and the atypical SCID, or the combined immune deficiency. So it's really a still an area that has a lot of controversies and discussions. But it's important because the management of these patients is different, because they are often not identified by newborn screening. They're often identified later in life, and often following infections and other complications. And some of them might actually survive into adulthood. So whether or not to proceed with allogeneic hematopoietic stem cell transplant has been a challenging discussion. They have a higher transplant-related risk on one hand and reduced survival benefits from transplant on the other hand. And so the risk benefit in these patients to proceed with transplant is higher. And these patients have more complications, higher morbidity, more frequent infections. And so it's been a challenging decision what to do with them. We do know that if you wait too long, they will develop autoimmunity, they will develop malignancy. So finding the right time and the right situation to proceed with transplant in these patients has been a challenge. I do think that gene therapy will eventually provide the best solution for these conditions. But I did want you to be aware that this is probably the next frontier of the management of patients with the less severe combined immune deficiency. So with this, I'll conclude my presentation. I'll just give you a few take-home messages. Newborn screening has changed the presentation and management of severe combined immune deficiencies. Some conditions might still be missed by newborn screening. Hence, it's really important that you maintain your vigilance. The earlier identification and better transplant techniques have significantly improved the survival of severe combined immune deficiency. For an increasing number of conditions associated with severe combined immune deficiency, gene therapy is becoming the preferable treatment option. And the next frontier that you will probably need to figure out is what to do with the combined immune deficiency group. I'll finish by acknowledging the members of the Division of Immunology here and my many national and international collaborators who have contributed to the data that I presented, and obviously patients and families. And in the remaining time, I'll be happy to answer questions. So thank you, everyone.
Yes, I actually have a quick question. It's about the patients who have ADA SCID. How often is it that for a patient to have like a later presentation of ADA SCID? We had a patient that we ended up being consulted on because it was found on genetic testing for something completely different, and their newborn screen was normal at the beginning. So just kind of curious about the incidence of that to have like in the back of my mind.
So the literature suggests that about 10, well, the literature suggests 10 to 20%. My experience is less than 10%. I probably say 5 to 10%, but about 5 to 10% of patients with ADA deficiency will have what is called a partial or later onset or later identification of their immune deficiency. There are some places, including Ontario and some places in Europe, where ADA deficiency is relatively more frequent because of the population, where they have actually added newborn screening for ADA deficiency to the newborn screening. And so they screen not for the low TREX, but they screen for the ADA abnormality itself, which appears earlier than the TREC. So to answer your question, I'd probably say about 10%, give or take 10% of ADA deficiency might be missed by newborn screening.
Okay, thank you. So
yeah, need to remain vigilant. Newborn screening, as its name implies, it's a screening, and like any screening, there's a positive predictive value and a negative predictive. There are false positive and false negative. Any other questions? So then I do actually want to talk about thymic transplants, because that's really one of the new hot topics in immunology, in the management of patients with primary immune deficiency. So as some of you might know, the most common T cell defect is actually DiGeorge syndrome that is often caused by 22q11. About 1%, give or take 1% of these patients have a severe, or what we call a complete DiGeorge syndrome, which means that they have 0 T cells. And these patients, it's really the school, the thymus, that is abnormal. And so doing a bone marrow transplant in patients who have a thymic defect will not lead to the correction of the immune deficiency. Because although you're sending in good students, the school is abnormal and you have not corrected the school. In the past, we didn't have good assays on how to distinguish these patients. And it really didn't make a difference because we didn't have very good ways on how to treat these kids. But in the last few decades, both thymic transplants have improved, and I'll talk about that in a minute, and our ability to diagnose these patients have improved. So now there are a few places that can actually take the patient's peripheral blood, they isolate the CD4 positive, CD34 positive cells from the blood and grow them outside of the body on an artificial thymus. And if they can show that these cells on an artificial thymus can grow, then they know that the problem is in the patient's own thymus. And in this case, they can send the patient for a thymic transplant. And that has made a huge difference in these patients. And there's now over 100 patients, both in the US and in Europe, who've received successful thymic transplants. So these thymuses are taken from babies who've undergone cardiac surgeries. During these cardiac surgeries, the thymic, which stands in the way of the surgeon in their approach to reach the heart, are removed, and these thymuses are collected and are processed outside of the body and then transplanted into patients who need these thymic transplants. And I don't know if you have followed any or seen any of these patients. It is a life-saving, amazing procedure. These thymuses are transplanted in the thighs of the patients, where T cells know how to reach these thymuses and start developing. And so patients who had no T cells before thymic transplants, all of a sudden have T cells. So again, I think one of the next frontiers is how to optimize the use of these thymic transplants, but the potential is endless. So again, I think there's a lot of things that are going to happen in the future, the near future, that you will be exposed to and be able to tell your patients. If no other questions, then I think I'll give you back 10 minutes of your time. Bao, any other questions? I can't see the chat.
I don't think I haven't seen any questions in the chat currently. But if there's no additional questions, then thank you so much again for coming to give us such a great talk. It's always great to kind of work through all the different SCID phenotypes, and I always have to wrap my head around it. So it's very much appreciated.
Thank you, and have a great weekend, everyone.
You too.
Bye.